Hello, everyone, and welcome. I'm Shelley Gunther, sonographer and clinical marketing manager here at Clarius. Thanks so much for joining us for today's live webinar, POCUS for Urologists, Reducing Costs and Maximizing Efficiency. You're among just over 500 urology enthusiasts in ultrasound who registered for this popular session, and we're excited to welcome urologist Dr. Mark Fetter for this session. In a moment, Dr. Fetter will show us how he uses high-resolution wireless ultrasound to improve access to important imaging, as well as procedural guidance. And these procedures have historically been performed by radiologists and sonographers, but as you'll see, POCUS performed by the urologist can improve many aspects of patient care. And just before we get started, a housekeeping note. Please use the Q&A icon at the bottom of your screen at any time to ask questions, and we'll address the questions following the presentation and the live scanning session, where sonographer Janae Smith will demonstrate a few tools that automate some urology ultrasound tasks, making bladder and prostate volumes even more efficient. Now, I have the pleasure of hosting today's webinar, and just before I introduce our guest, I'd like to share a couple of papers relevant to today's topic. Now, this first study is from Urology, February of 2024, and the objective was to assess the extent of formal point-of-care ultrasound or POCUS training, the current utilization of POCUS, and contemporary perceptions of POCUS amongst urologists by way of a survey. About half of the participants were in an academic practice, and 2/3 with more than 10 years in practice. 95% of the respondents agreed that formal POCUS training would be worthwhile during and after residency programs. They discovered that although POCUS is widely utilized in many practices, most urologists, unfortunately, haven't had formal training, but they do desire it. And the next paper is a very interesting abstract from the current urology reports, and I look forward to the findings. The authors will investigate current uses of POCUS in urology and the barriers that prevent standardization of POCUS curricula. It's been shown that urologists who use ultrasound at the point of care have high accuracy for diagnosing a variety of conditions, hydronephrosis being the most common. So as ultrasound becomes more accessible, its use in urology and urological training is likely to continue to grow and play an even more significant role in patient management. Now, just before we get started, I'd like to just put out a poll to get to know the audience a little bit better. When do you use ultrasound in your clinic? What procedures? Are you just using it for prostate measurements or bladder measurements? Kidney imaging? I'll give you just a couple of seconds more to respond. 3, 2, 1. All right, good. So lots of bladder measurements, lots of prostate measurements as well. I'm going to show you, talk about some really cool new technology to make that a little bit easier for you too. So good, across the board, most of you are using ultrasound in your clinic, which is great to see. All right, now I'd like to introduce today's guest. Dr. Mark Fetter is a board-certified urologist in Central New Jersey, where his practice encompasses the complete urological care of the patient. Dr. Fetter specializes in robotic and laparoscopic surgery, kidney stone treatment, erectile dysfunction, incontinence, and BPH therapies like green light laser and Rezum. He performed the first robotic prostatectomy and partial nephrectomy at St. Peter's Hospital, where he serves as chairman of robotics. He has been recognized as a top doctor in urology by New Jersey Monthly Magazine, and has also been recognized for his expertise in BPH treatment. And he's found ways to incorporate ultrasound into his practice, which he'll be chatting about today. Dr. Fetter, I will hand the mic over to you.
Thank you. Thank you for that introduction. Thank you, everybody, for taking your time out during the week to join us for this meeting. Today, we're going to delve into how urologists can utilize ultrasound in the office, how they can use it to improve their patient care, improve office efficiency. I was not able, due to the structure of our practice, have live patients in my office, as we're part of a very big group, and there's a lot of paperwork and red tape to get that done. We will have an ultrasonographer at the end who will do a live ultrasound to show you the technology that we actually use, the same company, Clarius, how it's done, and the images that can be obtained, the techniques we use to obtain those images. But why is it important to find new skills and offer these new services? There's many reasons why we evolve our practices. Most importantly, as medicine becomes more burdensome, we need to find ways to reduce stress in the office, improve our care, and maintain financial freedom. And that's why it's important to find new ways to save your time, improve patient care with new technologies that come along to us in the office. This is probably something that's not spoken about very often: physician burnout. Physician burnout affects about 50% of doctors across the board. It was worse during the COVID pandemic, increased to about 63%, and actually showed a big result of doctors phasing out maybe earlier in their career. There's a different measure of physician burnout globally across the board, with the various degrees of burnout across different countries. And this affects urology specifically. Urologists report some of the highest burnout rates amongst medical specialties. In fact, in 2022, the Occupational Information Network published data suggesting, and this is what they said, I can't say it's true for our opinion, but they said that the urologist is probably the most stressful occupation in the United States. And that was published from our government in 2022. What's not talked about ever, though, is physician suicide rates, which are actually climbing. Female physician suicide rates are 250 to 400% higher than women of other professions, while males are 40% higher than non-physician counterparts. And physicians actually have suicide ideation at some point around 10% across the board. Will have some kind of ideation across that. So our goal is to find ways to reduce our stress, improve our lives. So what are the signs and symptoms that we look for? We should look out for ourselves in case we're reaching that point. Emotional exhaustion is very important. We've all felt this to some extent. We have long days, overbooked schedules, difficult patient situations, unforeseen operative issues and outcomes. Definitely all experience something like that. Depersonalization can occur with increased volumes, lack of time. We feel stressed, we feel detached. We may lose even empathy in our job and trying to get patients through to get to the next one. Reduced personal accomplishments. You have a low self-esteem. You may not feel like what you got into medicine is what you're doing right now. There's increased physician employment models and entrance of private equity into medicine, which you may feel like you're just a cog in the system and you doubt your importance. And then we all have some physical symptoms that we go through on and off, with fatigue, poor sleep habits, no time for exercising, headaches that we often dismiss, but are part of just early burnout that we have to regulate and then sort of monitor for ourselves. All right. Burnout could lead to increased medical errors, malpractice suits, early retirement, turnover of physicians. This has a very big cost to the system. With doctors dropping out, can lead to $500,000 to $1.2 million of cost to a system. And urologists are even higher. With a busy urologist generating somewhere between $1 to $2 million, the cost can be extreme for that practice if they have to turn it over. And it could take about 6 to 12 months to replace a doctor, especially a urologist, in a very competitive area. It's not easy to always just have a new urologist come in, and that's lost patient volume and lost care because those patients are now having to forced to find other practices or delay their follow-ups. So the causes of burnout, I'm sure we go through, and I'm sure we can rattle off lists that affects us in our office, that affects us personally. Staffing issues, you have EMR issues, reimbursement issues, scheduling issues, prior authorization issues. It's endless, but the number one, I think, is the excessive paperwork that we all have to go through. Administrative tasks, coding, peer reviews. The more patients you see, the more charting there is. Lab, images, medical refills, patient questionnaires through MyChart. We get patients now emailing us directly through the office to now talk about questions right to us, bypassing nursing, bypassing the front desk. EMRs is an endless list of clicking to do simple tasks. To order a PSA takes 5 clicks. You have to have a secondary app now to order narcotics, order medication, testosterone refills. I'm sure we all experience this also. If your Wi-Fi goes out, EMR down, you come to a complete halt, increasing your stress as well. Also, linking your data with other hospitals to bring in information is extremely difficult at times. Urology-specific issues that we are all going through are declining reimbursement rates for medical procedures we do, increasing regulations in prior authorizations. In fact, we were just informed this week that we can no longer perform a cystoscopy in the office on the same-day visit. Every cystoscopy will now require a prior authorization. This, of course, will lead to a patient inconvenience, increased paperwork, delay the diagnosis to bring it back, overbook schedules on different days now. We all have to do disease-based protocols for standardization of care. If you're part of a big medical group, there's committees that come across with standardizations for different diagnoses, taking away from the personalization of your care that you may offer. We're going to put a poll up here before we get into the volume of patients that we see and how it impacts you. Take a moment and fill it out. Do you see less than 70 to 100 patients? This is a weekly volume. 100 to 125 patients a week, 125 to 150, or more than 150. Obviously, this is a per week volume, not a per day volume. Urologists obviously have their operative days and office days. So this is just averaged over the course of a week. All right, so majority of patients on this on here are seeing somewhere between 50, let's say 50 to 100 patients on a weekly basis. All right, so nationwide, this is what you see across the board. From what we see here, obviously, the busier area you live in, the more patients you're going to see. And a more urban area, you see somewhere between 80 to 100. And as you get into a less dense area, you'll obviously see less patients per week. So this is a percentile of what I can compile online about volumes of patients that people will see in their offices. Obviously, volumes differ based on the practice and model that you have. Most doctors are not seeing over 70 patients on a daily basis. This is not a weekly basis. This is on an individual full day, let's say 8 to 5. Less than 5% are doing this on a typical day. Most doctors are somewhere in 25 to 50 patients per day. In our office, on a full day's volume, we are now somewhere between 55 to 70 patients in our office on a busy day. If it's a week that follows a vacation, which you always regret taking when you come back to the office, it can be over 70 patients for that day. But this is not something that we do on a weekly basis. It's unlikely that a physician will see over 70 patients on a day-to-day basis going forward. But that brings up the priorities that we have. How do you adjust for your life-work balance, and what's the important things for you? Obviously, when we go into medicine, one of the most important things is physician care. We want to deliver the best care we can. We want to improve the quality of life of our patients, and we want to provide a caring and personal approach to that. And reducing administrative burdens can reduce burnout for this issue using EMRs and APs. And we'll get into those things that you can do to improve your work balance in a little bit. The second thing that I think is underrated is your priority is time. Time is invaluable. It's a commodity that we cherish the most. It's something that you can never get back in life. Once you lose the time, it never comes back. Time is limited. Lost from time with your spouse's kids. You miss endless events if you're on call, delayed interests of your own personal interests. Obviously, you all take different amount of call, weekends, depending on the structure of your group, whether night or weekends. But saving time and reducing your time and for yourself can improve your life and reduce your burnout. And the last thing is obviously income. Income is important. We all want to earn income. We all want to support our lifestyles, but money necessarily does not decrease burnout. Urologists earn more than other specialties, such as pediatrics, but obviously we have a higher burnout rate than those earning less than us. So what can we do? What are the strategies that we can implement to improve our lives and decrease our burnout and our stress? Delegating tasks to other providers. If you have a NP, a nurse practitioner, or a PA, a extender, patients that are within their global period, if you want to unburden yourself and have someone else see the patients that are within a global, taking out Foley catheters, changing suprapubic tubes, Eligard or advanced prostate cure injections, testosterone, blood work review, and refills. You want to unload the things that you can unload to other people to free up more time. You want to streamline your health record, your EMR. We'll get into the two things that really help in terms of saving your time and allowing you to see more patients with better care, such as templating and pre-charting and authorizations. You want to hand those off to someone else, whoever else can do that for you to free up your time. So this is, I think, very important for people if they want to see a lot of patients, see them with time and not worry about the charting while you're in the room with the patient. At this point, we're bringing computers, laptops with us. I think it's very hard not to have some EMR in the room with you when you're with the patient, charting, bringing up lab results, sending in medications, ordering blood results, and also documenting ultrasounds that we do now in the office. Using a template is very important. Creating a template can save you hours of work each day. Being able to populate an entire H&P can save 5 to 10 minutes almost per patient. So when a patient presents, let's say for a kidney stone, a ureteral stone from the ER, most patients are going to be given the same plan on that initial visit, whether it's, with medical expulsion therapy, hydration, straining, pain control. Maybe you'll give them alpha blocker, but they're all going to go on the same path, come back 3-4 weeks later, assess whether they passed a stone. Maybe you'll re-image them. If you have ultrasound in the office, that may be something we'll talk about later that you can use on their follow-up visit. When you see a patient for a painless gross hematuria, they usually enter the same pathway as well: culture cytology, labs, CT urogram, office cystoscopy, which now needs prior authorization, which you want to also offload. BPH is the same thing. Most of us have our way of dealing with initial consultations, and you can have that chart pre-populated and then tweak it as you need to, but the note can almost be completely written before the patient's seen if you know why they're coming in. Second thing that saves tremendous amount of time is pre-charting. So if I'm seeing 70 patients in a day, I'm going to show up 45 minutes before that day starts to do pre-charting, which means open all those notes so before the patients walk in the door, their notes are ready to be used or almost completely written. So a new patient note will be pre-populated with the basics, their physical exam review systems for the negatives, and we'll alter it as needed. If you know why they're coming, you can template that in as well. Any patient who's coming for a review is going to be, that date for that note will be written, and we'll add in any information that we need to help move that patient along. If they're coming to review a PSA, the PSA will be documented for today's visit already in the note, coming to review the PSA. And if I know the PSA is elevated already and documented on the trend that's going up, the MRI for the patient would be ordered already for a prostate MRI, or a prostate fusion biopsy could be ordered already if I know they're coming to review an MRI. If they're coming to review stone, or anything they're coming to review, if you know the plan based on that follow-up, your note for that patient could be nearly completely written, gives you time to make eye contact with the patient. You don't have to look at the computer. You can just move on to the next patient once you're completed. Everything could be ordered ahead as a temporary order, and then you can push go and set the orders up right when they're leaving. It's very important. Saves about 2 to 5 minutes probably per patient. If you're seeing 70 patients, you could do the math. If you're saving hours of work and you're getting home for dinner by just finishing the notes even before you leave the office. As of now, if we finish at 5 o'clock, 5:30, it does take about 30 to 40 minutes to finish up what you're doing in terms of going over any results that came through, any notes that you didn't finish yet. But we've definitely used the EMR now to sort of get out earlier and not spend their day just staring at a computer at home after hours. Finish the notes before you leave the office. Definitely improves your quality of life. And then we'll get into the ultrasound, which is the point of this visit. We'll talk about how we utilize that in terms of improving patient flow, reducing follow-ups, reducing paperwork, reducing authorizations, reducing chasing the results from whatever imaging center they go to. It can save multiple hours of time of all the patients we're seeing by avoiding delays, and then improve patient care as well. So what are the quick other things besides this that we could talk about? And this is not a talk on income or ancillary services, but just to quickly list them so they're on that you get a little taste of it. In-office medical dispensing, that really depends on the state you live in, whether your state allows you to offer in-office dispensing for, let's say, your ED medications or advanced oncolytics. It depends on your state. Definitely look into it, but it can give a revenue boost. Having a lab associated where you're sending your PSAs, your pathologies, all that, it's very important. Obviously, most of us have that already in our offices. These are urology specific. Having an extender can help free up your time, offload things that are not reimbursable, such as things within their global period, increasing follow-ups, improving patient volumes in the office as an extender. In-office ultrasound we'll get to. Having a lithotripter partnership with an ESWAL company can help improve it. It's still a carve-out that we're allowed to be associated with in terms of self-referrals. Urodynamics is a big one, having a service come in or doing them yourself, or having an advanced practitioner do your urodynamics for you in the office. Most of us are involved in testosterone replacement therapy, and we know how that works as well. So all help improve your income with decreasing stress and decreasing work. So in-office ultrasounds, why do it? What's the benefit? Number one, obviously, it improves immediate diagnosis. The assessment on the spot. Patient presents with flank pain. You can do an ultrasound right away to document hydronephrosis, presence of stones. Why is this important? I think, how many times a week do we see a patient that walks in complaining of my flank hurts? I know it's a stone. I've had a stone. When I was 20 years ago, I had a stone. It feels just like that stone. And we're like convinced trying not to roll our eyes, of course. But we know that it's not a stone. We know it's back pain. It hurts when they move, when they bend, when they twist. They feel better when they're sleeping. It gets better over the course of the day. We know it, but you show them an ultrasound right there. Hey, listen, this is not hydronephrosis. There's no swelling. There's no stone here. I believe it's back pain. But also, if it is a stone and you're convinced, you can show them this hydro, order your CAT scan, and move along. It gives you immediate diagnosis. Someone comes in with BPH symptoms, poor void, poor emptying. You want to know what the residual is. You do pre and post void. You can look for bladder stones, assess the size of the prostate, look for middle lobes. All these things could be assessed on the spot immediately. It's convenience to the patient. They don't have to go somewhere else. They don't have to wait for scheduling. They don't have to come back a second visit. It improves their satisfaction. They're happy with you. You're taking care of them all at one. Everything's being done in one location for them. Revenue, we'll get into the possible revenue boost later. But obviously, if you're doing the procedure, you're billing for that procedure. It doesn't take a lot of time to do an ultrasound. We'll have a display later about how an ultrasound's done and how quick it can be at the end of this discussion. And it saves time. No scheduling. No one has to go to radiology. No one has to chase down the report. It's, your workflow is better. You don't have to reschedule them another day to come back to review that as well. Take another poll here before we get into the ultrasound, how I use it in the office. How often do you use it in the office? Every day, 1 to 2 times a week, a few times a month, or never? You send them out or someone does it for you. Most people here are, I think it's half almost. Most people are doing some level of ultrasound. I think it's the same number of people that are probably doing prostate biopsies. Okay, so what ultrasounds do we offer? What can we do in the office as urologists? Renal ultrasounds, obviously, we can do complete or limited. Most of the time we're doing limited. You can do a complete if you want to document more. Assess the kidneys. You want to look for stones, hydronephrosis. I put the codes on here where I can find them for you to look at, and the reimbursement rates for the procedures that are averaged across the system. Brings about $100 or so per kidney ultrasound. Pelvic ultrasounds, limited is usually what we're using. Evaluate post-void residuals, but you also have to look for, bladder wall thickness, presence of bladder stones, prostate issues, put the prostate size in if you can. Transrectal ultrasounds, obviously, most of us seem to be doing them for prostate images, prostate biopsy guidance, or if someone's planning for a TURP, we use it before and after to document volume of prostate to determine the procedure appropriate for them, whether it should be open, simple, green light laser, or Zoom, what the procedure would be, and also to document the post-operative findings, and we'll go through some pictures later that we have. Scrotal ultrasound, we don't do ourselves yet in the office. We're trying to obtain a probe. We have to go through a lot of paperwork to get capital expenditures in our office, but obviously a lot of patients come in with vague testicular pain. A lot of people have avoided doing scrotal ultrasounds due to possible medical, legal issues, complications if something's missed, but obviously most of the time people coming in with testicular pain may have a small cyst. You have to look for varicoceles, hydroceles, things that would cause discomfort in the testicle. We don't have that yet, but it can be a booster to your office if you're seeing testicular pain 1 or 2 times a day, and you're seeing patients 2 to 3 days a week. You can obviously provide benefit to the patient. They're not going out to get an ultrasound. It's also annoying sometimes when patients do get scrotal ultrasounds and they want the results. They don't want to come in to review them. It's negative. There's nothing there. Then you have to call them on the phone, and it takes a lot of time after hours because you're not doing it during hours to call them with the results. So being able to do an ultrasound on the spot, hey, tell them this is normal, there's nothing significant, is a benefit to everybody, especially you if you're done at the end of the day and you don't want to make those phone calls that are just to say, hey, everything is normal, because they want to hear from you. They don't want to hear from a nurse that everything's normal. Doing 2 to 5 scans a day can generate a significant value at the end of the year. If you're seeing 50 patients a day, it's going to be a lot more than 2 to 5 scans per day. All right, what's needed? If you're doing ultrasounds in the office, this is a list that you really want to have to document what you're doing, not just for you, but for auditing, for someone else to take over your chart later and see what you did, why you did it. Medical necessity and indication is obviously needed. Why are you doing this? What condition are you looking up? What's the diagnosis that you're in question? Hydronephrosis, flank pain, voiding symptoms. And we'll go through a list of diagnoses that really are comprehensive. There's so many reasons to do ultrasounds. What is the procedure you did? Did you do a complete? Did you do a limited? Was it a renal, pelvic? You document the anatomy and the planes of the imaging that you're doing. And this can all be pre-populated in your chart. We use Epic. We have templates that we use to just pop a negative ultrasound into the chart, and then we can change presence of stone, presence of hydro, and everything else is documented the negative. And that brings the next thing is, What did you find? How do you interpret the findings? And it's very important not to just document what you do find, but also document what you don't find, right? If the patient does not have hydronephrosis, a stone or a renal mass, you want to put that there. If they have normal bladder wall thickening, there's no bladder stones, prostate's normal size, you want to document everything that's normal. Prostate ultrasound, you want to put the volumes in 3 planes, put the size. Is there a middle lobe? Is it obstructive? Is the patient in retention? You want to put everything there. Obviously, you want to put your name, the date, the time, location, what equipment you used, and then link it to an ICD-10 code. It won't be paid if you're not linking it to an appropriate payable diagnosis code. Modifiers are tricky. Doctors are really not great at modifiers, but there are some modifiers to know. If you're doing an ultrasound at the hospital and not in the office, there may be a difference in terms of the technical code versus the procedural code which you'll use. There are modifiers available for that if you're doing it at the hospital. So what are common diagnosis codes? They're really a long list for each ultrasound you'll do. For limited pelvic ultrasounds, someone's coming in with any voiding symptom, frequency, urgency, poor flow, feeling of incomplete emptying, dysuria, history of bladder cancer, stones, anything down the bladder, you have a reason to do a pelvic ultrasound to assess their bladder wall thickening, presence of bladder stones, what's their pre and post void residual. I had 3 patients come in on Tuesday each with a PVR over 3 to 500. Some, with long history, these are all second opinions for their issues, but not having that available to have an ultrasound on the spot would definitely delay a plan for these patients with a significant problem of high post-void residuals. Transrectal ultrasounds also have a significant list of why you would do it. Now, in our office, we try not to do excessive transrectal ultrasounds. Obviously, it's uncomfortable for the patient. And I try to use it in a setting where I gain information that allows me to treat the patient. So if someone's coming in for a prostate biopsy, we're going to do a transrectal ultrasound to guide and measure the prostate. And then otherwise we use it if we're planning an intervention. So if someone's not at the point in time where we're going to do an intervention, they're not ready mentally, they're not there yet, they're not in retention, there's no concrete reason, it's all subjective. We sometimes don't do it, but if I'm planning to do a TURP or a surgery on the patient, we definitely have them have a transrectal ultrasound before and after to document volume, middle lobe presence, to plan appropriately for the time of the surgery and the appropriate surgery. Renal ultrasounds, this is very common in our office, probably equal to limited pelvic ultrasounds. If someone comes in with flank pain, a history of kidney stones, they have a cyst with a Bosniak characteristic that we're monitoring with septations or calcifications, history of partial nephrectomy in the past for kidney cancer, gross hematuria, asymptomatic microscopic hematuria. Young people, we don't want to get a CAT scan if they're under a certain age because the chance of finding something significant is very low. There's tons of reasons why. I saw 2 patients today come in with elevated creatinines that they were sent to the urologist instead of a nephrologist, just to document the lack of hydronephrosis, that this is a medical renal issue. This is not an obstructive issue that needs to have surgery, so I can get them to the right care. If I don't have that available, then we're delaying their diagnosis and getting them to the right doctor. The lack of hydronephrosis, no obstruction. Let's get you to a nephrologist for your kidney issue. So this is important in our office, and I'll get into why this was important. In-office ultrasound is now advancing to the point of having wireless capabilities and AI capabilities. I don't think most urologists at this point are doing wireless ultrasound. And I'll get into a little bit in this slide about what happened in our office and how we got here. So it was before COVID. We had 2 standalone units that usually cost around $40,000 to $50,000 each. And one was on the fritz, it was going out. We needed to replace it. We had 6 exam rooms. And the way it used to work is that we'd bring patients in, and anytime they needed an ultrasound, which was not uncommon, a bladder ultrasound or a kidney ultrasound, they have to go back to the waiting room, wait for the ultrasound room to be open. And the rate limiting step of seeing all these patients was to filter them through one room where the ultrasound machine was, because if you unplugged it, you had to reboot it. And it was a very time-consuming fact to get them in and out of this one room with the ultrasound machine. So you had to sort of know you streamline your patients to be able to do this. We weren't able to do ultrasounds on patients if they were waiting. If there wasn't an emergency, we'd send them with scripts to get kidney ultrasounds because other people were waiting for prostate ultrasounds with biopsies. So we wanted to find something that would allow us to do ultrasounds in more rooms than just 2 and have a portability, mobility aspect to it. So we looked at a lot of different units. Will we put a standalone unit in each room? It's very expensive. It's $40,000 to $50,000 times 6 or times 4 if you want to just limit it. That's probably costly. So we brought in a lot of companies with their probes to show us them. The butterfly probe from GE, We had a company come with a laptop that plugged into just a laptop that you can move around. I think he wanted $30,000 to $40,000 for one laptop and one probe. And then I found this company online called Clarius that there were no reps available at the time to come and bring the probes, but they had a great customer service. Try it for 30 days. If you don't like it, just mail it back. And all you had to do was buy an iPad and then buy the probe and then connect the two. And I'll show you, this was the original. They have since improved their models, but this was the original one they have. You put a battery in it, you can clean it, you sterilize it. And it was the only company that I can find that had a endorectal probe, right? So we didn't want just an ultrasound probe that would allow us to measure bladder and kidneys, but we needed one that would allow us to do prostate biopsies and transrectal ultrasounds as needed. And it was the only company that we can find that has a wireless transrectal probe. And all you do is you buy an iPad. Let me see here. Buy an iPad and you download the app. And with the app, it links to the probe. And then you walk into the room with an iPad and a probe, and you have a fully functionalized set of ultrasounds. You have your EC7, your probe, and your C3, your bladder, your abdominal probe, and you're ready to go, fully functional. And you can toggle between them. And the benefit is it's the user face and interoperability, which we'll show you a little later with the ultrasound technologist, is amazing. So you can just, on screen, type in the name, type in the demographics, toggle between the probes. It's all touch screen. And the best thing about it was that when there's software updates, it just uploads to the iPad and transfers to the probes. You don't need to buy new software. You don't need to buy new probes. The customer service pushes everything through the app right into there. With the old systems, if the software was out, that's the end of the machine. There's no updates to the software on these standalone units, which was amazing. Sometimes it's inconvenient when the update happens in the middle of an exam, but it does happen. And the updates are great. They've even advanced now to offer AI, same price of the equipment, same equipment, but now there's AI to measure prostate volumes, and we'll show you later, and post-void residuals to measure bladder and volumes of the bladder. This was important to us not only because it improved the office flow. So now I have 3 sets of abdominal probes, 3 sets of prostate probes, and I can bring them between rooms, but I can also bring them between offices. So our main office has 6 exam rooms. We should have put a poll up of how many people have satellite offices and exam rooms. But we have 3 doctors in our office, each go to the same main office, but we all have satellite offices we go to once or twice a week. To put a machine in those offices with multiple rooms would be cost prohibitive. We wouldn't be able to put a standalone unit in 3 rooms in a satellite office to be used once or twice a week. So this allowed us to then pack this up in a Pelican briefcase, bring 2 probes and an iPad to a satellite office, and make it fully functional, where we can do prostate biopsies, we can do prostate ultrasounds, kidney ultrasounds, PVRs, everything now what we did in our main office, we can now bring to a satellite office. The way it worked before this was if a patient came with an elevated PSA, we had to make a scheduled appointment at our main office to come in for the biopsy. That can be distance from their house. They can live 30, 40 minutes from the main office if they live closer to a satellite office. And that was very inconvenient for the patient, for the doctor, for everybody. So this allowed us to fully functionalize a satellite office by just bringing the probe with us, bringing an iPad, and then doing everything on the spot for convenience to the patient. Everyone wins, everyone's happy. That was probably the biggest win for having a wireless probe system, was that it's transportable and fully functionalized a satellite office that you're there 1 day a week. You're bringing the clinic with you to the office when you come. It was amazing. These are some pictures of what the images look like, and we'll get into the live feed later. This is a prostate through the abdominal window, just to show you the picture. I'll get into some transrectal pictures a little later. This is how it works, just so you see what the clarity is. You just you pause it on the screen, and then you can just drop the calipers, and you can measure anything through the touchpad just by touching it back and forth. Now, obviously, this is a trans-abdominal measurement, not the transrectal measurement, but you get the point. You touch the screen, you bring up the calipers, it just drops. You don't drop the probe. Everything's done with just one hand on a touch screen. You don't have to roll the little ball around anymore. You don't have to type on the screen. You can have pre-populated annotations. You see on the top it says annotations. You can just drop anything on the screen to do your measurement. And when you unfreeze the image saves itself, and you can take as many photos, as many pictures as you like that way. This is one of my pictures that I went through my cloud. I didn't even get to that. When you're done with the pictures, you have a choice. You can save the photos, the images to a cloud where you have your whole database with your EMR, with your MR numbers and your demographics you can search through, or you can save them to your EMR. You can print them and then scan them in if you like as well. You can print them to an air printer as well. We use the cloud where everything is in one spot. We can search through MR numbers, compare pre and post treatments. This is a picture of a large prostate with a big middle lobe. This is another one where we measured the prostate volume of the patient before surgery with a massive middle lobe. And this is what it looked like after we did a green light laser on him, reducing the volume over 50%. And that's what we get with green lights, usually somewhere between a 50 to 75% volume reduction. Kidney ultrasounds, this is just showing you the measurement of the kidney, the clarity of what you get by doing a renal flank ultrasound in the office. And this is the ultrasonographer. We're going to skip it right now because she's going to do a live ultrasound for us in a minute on a kidney. You'll get to see it live, so we're going to skip the video here today. Hydronephrosis, someone comes in with flank pain, the history of kidney stones. I found the patient just last week. He came in with just a 1-year follow-up for kidney stones. I did an ultrasound and he had severe right-sided hydronephrosis. He came back today to review the CAT scan, and he has a 1-centimeter ureteral stone that could not be seen on the ultrasound, but he's now going to obviously get booked for surgery. He had no pain, just followed up at a year for his kidney ultrasound, and he had severe hydronephrosis. We didn't have to send him out for it. We speed up his diagnosis. We could speed up his treatment, and he'll be taken care of over the weekend because of his hydronephrosis and obstruction. His creatinine went up to 1.5 because we found the hydro. We did a BMP. These things allow for improved patient care, patient outcomes, faster diagnosis, and faster intervention. Bladder ultrasounds as well. Look for retention, look for bladder masses, prostate volumes, middle lobes. They're showing you the measurement of the bladder. Also can document thickened bladder wall if there's any history of cystitis. And this is a cool feature. This will show you the AI function that the probes offer, where the yellow documents the area of the bladder that the AI is recognizing as urine or water or fluid in 2 different planes, and will populate the volume for you very quickly. There's no scrolling, no measurements that you don't have to drop the calipers if you approve it. You can change the calipers if you don't agree with the measurements, but it's doing 90% of the work for you just by hitting the AI function, and we'll get into that a little later as well. Testicular ultrasound, scroll ultrasounds, we're not doing that yet, but obviously you can document testicular findings, epididymal findings, cysts, varicoceles, hydroceles, anything that you would want to look for on a testicular ultrasound. If someone's coming in with a hydrocele and you want to book them for surgery, but you just want to document the normal testicular findings, very easy to have in the office to speed up the treatment plan for the patient who's coming in with a hydrocele for treatment as well. This is just to show you a chart sort of a wireless to standalone unit and the impact. Obviously, portability is very important to us. Fits in a pocket, fits in a Pelican briefcase, no cords, no cart system. It's not tethered to a wall. You can go room to room with it. Much faster to set up. It takes just 30 seconds to sort of sync the probe to the iPad app. And the touch screen allows for faster documentation of the demographics, and then you're just ready to go. You can switch between probes just with the push of a button and picking up another probe with the same demographics in the system. Very easy to sterilize. The whole probe can be wiped down with the sterile wipe. No cords, easy to wipe down. The new probe systems don't have the external battery. The whole thing is one unit, and it charges through the unit. Easy to wipe down, no issues with infections. You can have multiple probes for the cost of one unit. So if one unit costs $50,000, and all in 2 probes and an iPad costs $12,000, you can get 3 to 4 of them and still save money on having multiple probes available and multiple units available for different rooms. So if you want to do an ultrasound or a bladder or prostate in one room, and you want to do a prostate biopsy in another room, everything's easily just grab a different screen, a different iPad, and you're ready to go. Bedside results, the patient can see it. The iPad is very easy to move around to show the patient what you see, and it can be shown to them. It's not fixed to the machine. And most important at the end also is their customer support, adaptability. Software is constantly upgraded, constantly adding new features. They take advice, they take feedback, and try to integrate everything that you feel would help you. This is what it looks like, literally. When I go to my satellite office, I grab a Pelican briefcase. In the briefcase, we pack, this is because it's the first edition probes. There's 2 batteries in the back on the left. the C3, the transrectal ultrasound. We bring biopsy sheaths and guides with us, so we're ready to go. That's what the iPad looks like on its stand, ready to go. We enter the demographics and prep the probe, and we're ready to do a biopsy on the spot. To the left is what the probes look like. The C3 is in the middle, the most used probe probably for bladder ultrasounds and kidney ultrasounds. The left is the endorectal probe, of which the only wireless company that I know of that offers the endorectal probe at this point, and the small parts probe on the right for, I think it's the L15 or something, that you can use for scrotal ultrasound and testicular findings. Very convenient, very useful. I hope this was helpful. I hope that the presentation coming up with Ms. Smith to help show you how the ultrasound's done and the capabilities of the system are helpful as well. Please put any questions below.
Awesome, Dr. Fetter. Yeah, we're going to hand it over to Janae, and she has a model. She's going to show you how to kind of get set up and scan the bladder and the prostate, and show you how easy it is to, or how to do the measurements in the app. And then if there's time, she can do a quick demo of kidney ultrasound as well.
So we'll start in a transverse orientation over top of the patient's pelvis. And we'll start with the prostate. So we're going to angle down towards the patient's pubic bone. And we can see the prostate come into view here. And to activate the AI, we're going to tap the AI icon here on the left-hand side of the screen. And we can see there's a selection of bladder volume or prostate volume. And so we'll select prostate volume now. And we can see that the prostate has been highlighted for us with a opaque masking overlay. And we can adjust the opacity of the overlay by selecting the teardrop AI icon and selecting the AI opacity. And now when I drag my finger to the right, it increases the opacity, and to the left, it decreases the opacity. So when I'm happy with the opacity of my image, I can go ahead and freeze. And we can see here that the calipers have been placed for the height and the width of the prostate. And it displays the measurements on the top left-hand side of the screen. On the lower right-hand side of the screen, we can see that camera icon flashing, prompting us to save the image. So we'll save the image, and it also saves those measurements. We'll rotate the scanner 90 degrees into the sagittal orientation. And it's recognized this as a sagittal view, and it's displayed on a banner here on the bottom of the screen. And when we freeze the image, the calipers are placed for me. If I wanted to adjust the placement of these calipers, I simply drag my finger on the screen until I'm happy with the placement. And now we can see on the top left-hand side of the screen, the prostate volume has been calculated and displayed. And now when I save the image, the images as well as the calculations and measurements are saved for me. We'll go live here again. Just a note that the prostate AI is not yet FDA approved, so it's still for educational purposes. And now we can switch over to the bladder volume calculation. So we again select this AI icon on the left-hand side of the screen, and we'll select bladder volume. And again, it has recognized and highlighted the bladder for us. So we're in a transverse orientation. And when we freeze the image, the calipers are placed. This time they look perfect. I don't need to make any adjustments. We'll save the image and those measurements. We'll rotate the scanner 90 degrees for the sagittal measurement. And we'll freeze the image. And we'll save that.
So Janae, you could do this post void as well, right? Like when
that's right.
Go to the bathroom, and yeah, nice.
Yeah,
it's pretty accurate.
It is really accurate, and we can see on the left-hand side of the screen here, it's calculated the volume for me, and that was really quick. There's no playing around on calculators, which is nice. We're doing that measurement 2 times. So now we'll head back to the patient demographics page. And here, this is where we would enter the patient information. So name, birth date, any indications for the scan. There's also an area to enter the PSA levels. So we'll select 3 for the purpose of our exam. And then when we scroll down to the calculations page, we can see that the PSA density has been calculated. We can see all of our measurements from the prostate and the bladder, and our images are saved here, and we can review all of those. If we scroll down a little bit further, we can see an area here for impression. So any findings from the scan that we can make note of them here. So the AI makes it a lot easier and quicker to measure those volumes. Do we have time to have a quick look at the kidneys?
Yeah, we could have a quick look maybe at one of the kidneys, sure.
Okay, I'll get you to roll onto your side, Mike. So we're gonna switch our preset to abdomen. And I like to have my patient's arms stretched out because it kind of stretches the anatomy out and gives us a better view of the kidney. I'll put a little bit more gel here. So the kidneys are located generally in the area between the 11th and 12th rib. And depending on the patient's body habitus, you can play around a little bit with positioning. I'm scanning the patient decubitus, so on the side. And we're getting a nice view, especially of the upper pole of the kidney here. And we can see as I'm scanning the patient's or the kidneys kind of moving up and down a little bit. And so if we want to have a better look at the kidney with it stationary, we can get the patient to hold their breath, and that'll make the kidney to stop moving, and we can assess it. So we'll scan all the way anterior and posterior on that kidney. So you can see how it has stopped moving, and we'll freeze our image there. You can breathe. So that breath hold really helps to clear up the image. So when we're scanning here, we're looking for things like hyperechoic stones, any hydronephrosis in the renal pelvis. It looks like this is a nice healthy kidney here. So we'll rotate our probe 90 degrees into the transverse orientation. I'm going to come a little bit more anterior for this one because I find, because we're moving a little bit further up and down on the kidney, the rib shadows seem to get in our way. So I'll get our patient to take a deep breath in again and hold it this time. So we can scan all the way from the upper pole, mid pole here, and down to the lower pole of the kidney to get a nice assessment. We can see the vessels moving into the kidney here. We turn the color Doppler on, we can see the renal artery and the vein entering the kidney. So we know that's a vessel and not a dilated ureter when we turn the color on. We can see that nicely. We've ruled that out.
Nice. Thank you, Janae.
Thanks, Shelley.
Yeah, and thanks, Dr. Fetter, and thanks to Mike, our model. Now, just before we open the floor to live questions, I'd like to put out just another quick poll. We'd like to help everyone continue your journey into bringing handheld ultrasound into your practice. So please complete this poll to let us know if we can provide further information, and click on as many as apply, please. And while you complete that poll, I'd like to take a minute to introduce you to the Clarius HD3, which you've seen, and the world's only third generation line of portable ultrasound scanners. Clarius HD3 delivers wireless ultrasound for urology with an easy-to-use app, as you've seen, but powered by artificial intelligence and connected to the cloud. Our Clarius high-definition C3 scanner is specifically designed to image the bladder and the kidneys and to guide procedures. We also have the EC7 endocavity scanner for prostate imaging and procedural guidance, as Dr. Fetter mentioned. And the third urology scanner is the L15, which delivers really nice high-resolution imaging for scrotal and penile applications. Now, each scanner delivers image quality of larger ultrasound systems, but at a fraction of the cost. And with artificial intelligence replacing complex knobs and buttons, it's as fast and easy to use as your smartphone. Clarius is also wireless, freeing up space with zero footprint for ultra portability in a variety of settings. So you get free movement with no wires getting in the way and touching your sterile prep area, and no wires to clean either. Included with your Clarius scanner is a free app for your iOS or Android devices for unlimited users, and available with our membership or one-time license. Clarius Cloud can manage unlimited exams from anywhere. Your membership also includes in-app classroom videos on a variety of urological ultrasound applications and onboarding with a clinical specialist to build your skills. Now, membership also includes dedicated presets, as you saw today, the bladder and the prostate and abdomen. We also have voice controls, actually, which we forgot to demo for you, but it's really nice. It's a way to operate the app. You can increase or decrease gain or depth, all with voice controls. Now, this also includes FDA-approved bladder AI that you saw today, and the soon-to-be FDA-approved prostate AI, hopefully in the next month or so. So I invite you to complete the poll for additional information. And if you've already done so, we will get back to you in the coming week. And just to let you know that you'll be receiving an email with a PDF file of all of the slides, as well as a link to the webinar recording. All right, now I'd like to welcome back Dr. Fetter to answer your questions. So we'll see if we have any questions here.
Can Ms. Smith bring up the interface of the app? I think people have some questions about what functionalities exist. I think we ran through how to do an ultrasound, but I don't think they saw all the capability that you actually offer in the probe. I think it's important to show that what you can do with just one hand with a touchscreen. So we're going to show the interface.
While you're getting set up there, Janae, there was one question about, are you doing biopsies with the Clarius EC7 probe? And what needle, do you use a needle guide? Or a biopsy
so I'll
gun?
answer that right now while she's getting the interface ready. So I actually pulled it up on my phone while we were talking. So yes, we do. There is a clip-on, just like all ultrasounds, a clip-on probe that we use to guide needles for injections, placement of markers for fiducials for radiation services as well. Civco is a company that makes most prostate biopsy guides. I'm sure most urologists here may know that, CIVCO. They have a website where you can order any prostate guide clip-on for ultrasounds of any company. So I was looking it up because we have them in the office, and there's a guide that comes standalone, and there's a guide that comes with condoms and lube and everything else you may need with it. But your office may not need that, as you have everything available. I think it's the number I found online was 610-1429, which is a disposable endocavity needle guide specifically made to clip on and be secured to the Clarius EC7. So that's Civco company. Then you just have, if you Google Civco Clarius probe, you'll find it too. But yes, there is a guide to clip onto the probe to do image guided procedures. Yeah, so there you bring up there. So here's your options for people asking questions about blood pressure measurements on the bottom. When she opens the bottom, you can measure just all functionality
like
of the probe, color Doppler, power Doppler, and the like. Yeah, so just wanted them to see the functionality that you offer in terms of
there's definitely color Doppler, power Doppler, pulsed wave.
Perfect. Now, as urologists, we don't typically use those. We're there, we're not. Some do, but as a general aspect, we're trying to rule out urological causes of renal dysfunction. And then if they need a nephrologist, we'll send them to a nephrologist. But the functionality is there if needed.
Yeah. And then there's a whole host of different measurements that you can do in the tools menu. So you can, like Dr. Fetter was saying, you can get resistive indices if you do a trace. You can get peak and diastolic velocity. There's an auto trace function and all of that. So, yeah. All right, so hopefully that answered the question. All the capability available with FDA approval other than the prostate exam. Yes. So we're just pending FDA approval. It's been submitted. It should be within the next month, but other AI capabilities as well as other advanced features, everything is FDA approved. We are a Canadian company, but yes, we go through FDA because the US is a big market for us. So. All right, well, it looks like we are at the top of the hour here. So thank you for all of your questions. And if we didn't get to your question, we'll follow up with you by email in the coming week. As I mentioned, you'll receive a PDF copy of the slides and a webinar recording in the coming days. So keep an eye on your inbox. So thank you so much, Dr. Fetter, for sharing all of your insights. A very big thank you to all of you for joining us. And I hope you have a wonderful rest of your day.